Welcome to our presentation entitled The Vitals on Vital-amines, Vitamins and Supplement Counseling Points for the Community Pharmacist. Hi, I'm Peter Kreckel. I'm an adjunct assistant professor of pharmacology in the Department of Physician Assistant Sciences at St. Francis University in Loretto, Pennsylvania. There I teach all of the pharmacology to the physician assistant students. I'm also a full-time pharmacist at Thompson Pharmacy on Brad Avenue in Altoona, Pennsylvania, and I work about 40 hours a week there, like most of you do, counseling patients and taking care of both their prescription and over-the-counter needs. Let's discuss the objectives for our lecture. We're going to discuss the regulations pertaining to vitamins and supplements concerning their use in the modification of disease states. We're going to find out who in our government is responsible for these vitamins and supplements. We're going to outline the specific water-soluble and fat-soluble, the pharmacology of these vitamins, as it were, and the disease states that they prevent. We're also going to describe vitamin deficiencies that can be caused by those prescription drugs that we're dispensing, and our role as pharmacists and the roles of pharmacist technicians in recognizing and the treatment of those deficiencies. And finally, I'm going to provide you some in-house education programs for community pharmacists. When we look out from our prescription benches and see just the rows upon rows upon rows of vitamins, we know that vitamins are indeed a big seller. So most of the information that I've been able to share with you and comes from the website I have listed here. It's a government website and its focus is primarily on vitamins and food supplements. More than 1/3 of all Americans will take multiple vitamins. About 1 in 4 children takes a multiple vitamin, but the use increases with age and during adulthood so that by the age of 71, more than 40% of your patients, 40% of those senior citizens out there will be taking a multivitamin. Adolescent population are least likely to be taking them. Well, we all know as pharmacists that the vitamin industry is not regulated nearly as tightly as that drug industry. So who actually is watching over the industry that provides us with the vitamins and supplements? Well, it's the FDA, and it's loosely regulated. The dietary supplements are covered by the Dietary Supplementary Health and Education Act of 1994. The DSHEA 94 is who's governing those supplements that are on our shelves. And a dietary supplement are considered to be a vitamin, a mineral, any botanical or plant-based amino acid, enzymes, organ tissues, glandulars, and metabolites. These dietary supplements fall under the categories of foods and not drugs, but being under the umbrella of the FDA, Food and Drug Administration, they do watch over them through that DSHEA Act of 1994. Well, do they have FDA approval? And this is where things get a little bit murky. It's the responsibility of the manufacturer to ensure product safety and product efficacy. They do not need FDA approval before marketing, nor do they need to be registered with the FDA before being produced or sold. The burden characteristically is on the FDA to prove that the supplement is unsafe. When we think back to the 4 stages that a drug has to go through to get FDA approval and that ongoing marketing, this is a direct reversal. It's the burden is on the FDA to prove that a supplement is unsafe. The manufacturer does not need to prove that the supplement is effective, unlike for drugs. The manufacturer can say that the product addresses a nutrient deficiency, it supports health, or reduces the risk of a health problem if that's true. If the manufacturer makes a claim like this, it has to be followed by the statement that this statement has not been evaluated by the Food and Drug Administration, and this product is not intended to diagnose, treat, cure, or prevent any disease. And when we look at most of the products on our shelves, we're going to see that statement appear on all of them. Well, let's talk about vitamin deficiencies. Well, vitamin deficiencies are usually insidious in nature. They just don't have an overt presentation. They're usually nonspecific. A physical exam is rarely helpful in early diagnosis. Most characteristic physical findings are seen much later in the disease. And when we do see them, they're real nonspecific. Glossitis, swelling of the tongue, cheilosis, are seen with deficiencies in many of the B vitamins. These abnormalities suggest a nutritional deficiency, but not of a specific nutrient. It's very nebulous when you look at these particular anomalies that patients present with when they have a vitamin deficiency. In the United States, however, we're much more likely to see excess vitamins than deficiencies, and we'll see those excesses with vitamins A, D, and vitamin B6. Who's at risk for these vitamin deficiencies? Well, pregnant women obviously are, as well as infants and elderly, people with chronic diseases, alcoholics, and strict vegetarians. Also, our undernourished populations can be those homeless type people, hemodialysis patients, people in the hospitals on TPNs, food faddism, those inborn errors in metabolism, and a lot of times we'll see that in Pennsylvania. In some of our Amish and Mennonite sects, we'll have inborn errors of metabolism, and in some cases those anorexic and bulimic patients. What we're going to talk a lot about for this lecture are the drugs that we're dispensing behind the counter that can cause vitamin depletion. Well, let's talk about the labeling of these products. The FDA does regulate that label content of health claims. The claims that can be used on food and dietary supplement labels fall into three categories. They can be health claims, they can be nutrient content claims, or they can be structure function claims. So some examples of those rather nebulous permissible supplement claims are going to be: it supports a healthy immune system, it builds strong bones, it can maintain bowel regularity, or decreases blood platelet stickiness, or a good source of vitamin C. Notice here that no disease states are mentioned. Notice it doesn't say things like prevents osteoporosis, or can control constipation, or decreases risk of stroke, or prevents scurvy, but it says what the supplement is doing on a very basic level without mentioning the disease state that it is trying to treat. Well, what do these vitamins do once we swallow them? Well, vitamins in general work in the body by three different mechanisms. They can be coenzymes. Vitamin K, one of our famous ones for the clotting mechanism, that's the one that's antagonized by warfarin. Most water-soluble vitamins are coenzymes necessary to speed along those reactions in our bodies. Antioxidants like vitamin C and E help scavenge up those free radicals. And hormones, vitamin A and D are hormones, especially vitamin D we think about because we can produce it ourselves in our skin. So that term vitamin was coined in 1912 by a Polish biochemist. His name was Casimir Funk. And the name vital and amine meaning of life, because it suggested in 1912 that these organic micronutrient food factors prevented beriberi of all things. And perhaps other dietary disease might be because of these chemical amines. So they were vital amines necessary for the functioning of our body, and that all came about in 1912. So we're a little over 100 years in celebrating vitamins being elucidated. Well, how much should I take is always a question we hear, and the recommendations from our government are nothing short of alphabet soup. We see here an RDA, which is the one we probably see the most, which is a recommended dietary allowance, which is the average daily level of intake that you need to provide your body with what it needs to function. We also have an adequate intake, which is established when evidence is insufficient to develop an RDA, and it is set at a level that's assumed to ensure nutritional adequacy. We also have an EAR, which is an estimated average requirement, which will meet the requirements of about half of the population. It's usually used to assess the adequacy of a nutrient in populations, but not individuals. For individuals, you're going to use the RDA. And the final number that we'll want to take a look at is the tolerable upper intake level, or the UL, which is that maximum daily intake, unlikely to cause adverse health events. It's that number that you should not exceed so we don't develop any hypervitaminosis. As we can see from this next slide, that the MDR for water-soluble vitamins is probably going to be provided by most of us eating a normal diet just through our diet. We see vitamin B1 thiamine at just 1.2 milligrams per day, and think we dispense 100 milligram tablets. And those dietary sources are peas, pork, legumes, and whole grains. Riboflavin, vitamin B2, liver, eggs, dark greens, and whole grains. Niacin is liver, fish, poultry, meat, whole grains. Without reading this whole slide to you, you can see that it's pretty much a balanced diet, should get you most of everything. The one that we want to really pay attention to, however, is cobalamin, vitamin B12. We see meats, liver, kidney, fish, eggs, meat, milk products, oysters, and shellfish. True vegans, people that will not eat anything of any type of animal origin, could be deficient in vitamin B12. That's the one that they'll need to supplement if they're doing nothing more than whole grains, beans, and things like that. They can get all their proteins from their beans, but they're not going to be able to get vitamin B12. So vegans in particular are going to need to supplement with vitamin B12. And ascorbic acid, our good friend, we see with any plant foods, with citrus being the highest. So eating a normal diet's probably going to provide most people with the adequate vitamin intake they'll need to keep functioning. Well, let's review some vitamins in particular, and the first one is going to be vitamin B1 or thiamine, a water-soluble vitamin, and its deficiency state is commonly seen in people with alcoholism. It's also associated with malabsorption, dialysis patients, and protein calorie undernutrition. And dry berry and wet berry are its signs. We'll see heavy alcohol intake can cause that Wernicke-Korsakoff psychosis, and that's why we need to supplement our alcoholics with vitamin B1 or thiamine. We'll see the neurological deficits. We can even see EKG abnormalities as well. And we can also see marked peripheral vasodilatation with the wet berry. Again, it's not commonly seen in the United States unless our patients are undernourished or alcoholics. Vitamin B2 is riboflavin, and riboflavin deficiencies were common at one point, but now that all the white flour that we eat is fortified with these B complex, very rare to see a riboflavin deficiency. Its deficiency states will be inflamed lips, cracks and sores at the corners of the mouth, stomatitis and inflammation of the oral mucosa. We can see some corneal vascularization, amblyopia, dimness of vision, and sebaceous dermatoses. The health benefits conferred by adequate nutrition, stress and cataract prevention and depression. We'll see a lot of our neurologists recommending riboflavin as a supplement because there have been some incidental reports of migraine prophylaxis being effective with vitamin B2. I've not seen great results with it, but many of the neurologists will recommend the patient supplement with riboflavin or B2 for migraine prophylaxis. Interactions and adverse effects, there's not really a whole lot, and it's not toxic due to that limited gastrointestinal absorption. Most of us pharmacists are very familiar with vitamin B3 or niacin, sold behind the counter as slow niacin. The deficiency state is pellagra, which translated means rough skin. Deficiencies of vitamin B3 will include the 3 Ds of pellagra: dermatitis, diarrhea, and dementia. The health benefits conferred are decreased cholesterol and triglycerides. Questionable about that decreasing the risk of heart disease. Recent studies are showing that it has a very favorable effect on the lipid profile, but doesn't seem really to decrease the incidence of cardiovascular events. So it is interesting to see how niacin is going to shake down. Right now it seems most docs are sticking with their statin therapy. Its adverse effects, we're all familiar with the flushing, the GI upset, and it can also increase our blood sugar levels. The supplemental doses we'll see over the counter are 50, 100, 250, and 500. They are not sustained release. They're the immediate release, so we do see a lot of flushing with them. Slow niacin is sustained release and available over the counter at 250, 500, and 750. And then we have the no flush niacin, the inositol hexaniacinate, which is not as effective for hyperlipidemia. Let's talk about using niacin for lipidemia. The AIM-HIGH trial was stopped 18 months early because interim analysis showed the lack of benefit of simvastatin niacin versus simvastatin alone. It just found that there wasn't a whole lot of benefit with adding the niacin to the statin. At doses over 1 gram per day, we could see an increase in rhabdomyolysis with niacin use, especially if that patient is on a statin. So you're only going to use it if the risk is worth the benefit. The OTC niacin, and a lot of people will know that niacin will lower their cholesterol, and when they see the price of the prescription Niaspan, they're always looking for a cheaper alternative. The immediate release niacins are more likely to cause flushing, especially with that first dose. We know that we can block the flushing effect by giving a prostaglandin blocker like aspirin, 325 milligrams. The long-acting niacin, slow niacin, is more likely to cause liver problems, so do not recommend slow niacin for treatment of hyperlipidemia. It should not be used for that. If we're going to treat hyperlipidemia with niacin, either the immediate release and then dealing with all that flushing, or using Niaspan, the prescription product, which is available generically as extended release niacin, also can be effective. So no matter which one you use, it is a good idea to get that aspirin 325 on board to prevent that prostaglandin-mediated vasodilatation. Vitamin B5 is pantothenic acid, and it's used to break down fats and carbohydrates for energy, like all of the B complex does. It's critical to the manufacture of red blood cells as well as sex and stress-related hormones, those adrenal hormones. Vitamin B5 is also important in maintaining a healthy digestive tract, and it can be very helpful for other vitamins, particularly with B2 or riboflavin. We want to avoid B5 supplementation with the cholinesterase inhibitors like donepezil, rivastigmine, those Alzheimer's drugs. It can really cause an increase in the side effects caused by the cholinesterase inhibitors. So it is not recommended to give B5 supplementation along with the cholinesterase inhibitors. To us seasoned pharmacists, vitamin B6 is indeed an old friend returning. Anyone with the amount of years experience that I've had, 30 and over, will remember when we had a product called Bendectin that contained the doxylamine and pyridoxine that was used for the nausea of pregnancy. And that drug went away back in the very early 80s, one of the first drugs that I can recall that came off the market due to the potential for lawsuits. So vitamin B6 is that vitamin that we often think of as the drug for women. It can help with PMS and primarily for the nausea of pregnancy. Deficiency states with vitamin B6 are not real common. If you do see them, that would be anemia, convulsions, seborrhea-like skin reactions, and neuropathy. Those health benefits conferred by the optimum daily allowance, it may alleviate those PMS symptoms, improve the mood, decrease the risk of heart disease. It'll stimulate the immune system, and as we said, will probably help decrease the nausea of pregnancy. The good news is with a drug like this, it is used for our pregnancy population. It is pregnancy category A. Some of the drug interactions we can expect, again, are not real commonly seen. There is an interaction mentioned with levodopa. Vitamin B6 decreases the levodopa effectiveness by increasing its peripheral metabolism. Not such a big deal now that we have a product with the carbidopa containing that, as we all know, blocks the peripheral metabolism of levodopa. So a drug like cinnamon or its generics, the carbidopa, levodopa, really don't make this such a big deal, the B6. Most of us older pharmacists will remember when there was a product called Larabec, which was a vitamin supplement without the B6 for our levodopa patients. Also, in interactions mentioned with phenytoin, serum phenytoin levels can be decreased. Adverse reactions, we can see unstable gait and numb feet. The dosage is 25, 50, 100, 250, and 500 milligrams of a tablet a day to ward off PMS, somewhere between 440 and 500 milligrams per day. That's a pretty significant range. But vitamin B6 we're going to think about as one of those that's primarily going to be used in our pregnant population. And yet another common vitamin that our women should be taking, and I tell all of my female students at St. Francis this, if you have functioning ovaries, you need to be taking folic acid. Vitamin B9 or folic acid is required for that nucleoprotein synthesis and maintenance of the normal red blood cell function. It stimulates the production of red and white cells, platelets, and we'll see its deficiency being manifested as megaloblastic anemias, large cell anemias. It's converted to tetrahydrofolate, which is the active form in the gut, and it's vitamin B12 dependent. Oral synthetic folic acid, however, is completely absorbed following administration, even in the presence of malabsorption syndrome. So our body sucks this one up pretty easily out of the GIT. It's indicated for use in megaloblastic anemia due to deficiency of folic acid. One of the warnings, though, we have to give with this is it can mask the symptoms of pernicious anemia. If a patient has a vitamin B12 deficiency, has pernicious anemia, we can mask the hematologic symptoms with folic acid and still allowing for the nervous system damage to go on unchecked due to the B12 deficiency. So we shouldn't just be treating every megaloblastic anemia with folic acid. We need to ascertain whether it's a folic acid or a cyanocobalamin deficiency. Folic acid, well, who needs it? I tell all the girls in my class at St. Francis, all of you need to be taking at least 400 micrograms per day. For pregnancy, we see a decreased incidence in spinal bifida and anencephalopathy. Those are those neural tube defects. And what's so important with neural tube defects is they occur right after conception, before most women know they're pregnant, that this very primitive nervous system is being formed in their unborn child. So we want to make sure we have that folic acid, at least 400 mics a day, on board. So we want to supplement to 400 to 800 micrograms before pregnancy occurs. And if that patient is a high risk for spinal bifida because of previous history, you can use up to 4 milligrams or 4,000 micrograms of folic acid a day before pregnancy. We have some drugs that can lower folic acid. We have seizure medications, those cytochrome P450 inducers like carbamazepine, phenytoin, phenobarb, the big ones. Oral contraceptives can also lower folic acid. So if a woman's been on oral contraceptive therapy, really important for her to be taking folic acid supplementation if she stops the drug and decides to get pregnant. Proton pump inhibitors and H2 receptor antagonists will decrease the acid and lower absorption of folic acid. And of course, most of us are familiar with methotrexate for rheumatoid arthritis as very much lowering folic acid, and those people need supplemented with between 2 and 4 milligrams of folic acid per day. Vitamin B12 or cobalamin, its source is muscle meats, liver, and dairy products. It's not found in vegetables, and the vegetarians are at risk, and the true vegans are definitely at risk, and your true vegans should be taking B12 supplements. It's involved in cell division and the recycling of folate. Folate deficiency is observed as a feature of B12 deficiency, so those symptoms of deficiency are reflected in organ systems with rapidly duplicating cells. Your gastrointestinal tract, your neurological tract, and of course your red blood cell formation system. So the deficiency, we're going to see pernicious anemia is the first thing we'll be able to see, obviously. It's a megaloblastic anemia, a large red cell anemia, and we can also see neuropathy being caused. Remember, those large doses of folic acid will correct the hematological symptoms, but those neurological symptoms, the damage, the neuropathies will continue to progress even though we've fixed the hematological symptoms. Some causes of vitamin B12 deficiencies, we said about vegans needing to supplement for it. Decreased production of intrinsic factor due to pernicious anemia, gastrectomy, or bariatric surgery. And this whole population we're going to talk about in a few more slides is our bariatric surgery population. They're going to be B12 deficient. Those that have the Helicobacter pylori infection, that infection in the stomach that can cause those duodenal or peptic ulcers. And decreased ileal absorption of B12 due to surgical resection and Crohn's disease. Something very interesting about vitamin B12, we think of it as a water-soluble vitamin, that it flushes out of the kidneys and out of the liver very quickly. Well, the truth is it has a biological half-life of about a year. Therefore, it takes about 2 years to elapse before you'll see any clinical manifestations. We're all carrying about 2 years of B12 on board in our livers. So by the time someone gets bariatric surgery a couple years later is when we're going to see the manifestations of the B12 deficiency. The same is going to hold true with our metformin patients that have been taking metformin for a while. It takes a while to develop a B12 deficiency because of the amount of B12 we have on board. A couple years ago, we retail pharmacists were all scrambling for injectable vitamin B12, and those generic drugs that seem to be in short supply can be frustrating for all of us, and this was indeed a big one. Well, what we had found is a lot of literature was saying, it's not such a big deal if you can't get the injectable B12. Just simply flood the GI tract with vitamin B12 in the oral form. And we saw a lot of our patients being switched from the not available injectable B12 to the oral vitamin B12, and they've been progressing rather uneventfully. So we're going to begin with 1,000 micrograms per day. And although this is poorly absorbed, about 5 micrograms is really all that you need. So you see it's less than 0.5% is what you really need to absorb out of your gut. About 1% of vitamin B12 in supplements is absorbed when given orally, and even people without gastric acid or intrinsic factor will probably just pick that stuff up anyhow. So be sure to give enough, about 1,000 mics a day of oral B12, and suggest oral B12 for your mild to moderate deficiency. Not everybody needs to go and get a B12 shot because they have a deficiency. Injectable vitamin B12 can be in good supply. Sometimes it comes, sometimes it goes, so who knows what next week will bring us. Cyanocobalamin is available as 100 and 1,000 microgram per mil injections. Ideally, we're going to start our patients on 1,000 mics IM every day for 1 week, and then we can switch it up to IM every 4 weeks, and then about 100 to 1,000 mics IM every month for prevention. And recommend those B12 shots for the patients with more severe deficiency or those who aren't absorbing it due to the diarrhea, vomiting, or bowel resection. Only your most difficult patients should now be getting injectable vitamin B12. Well, we got from vitamin B1 to B12 in a hurry. It seems we skipped a few numbers. So what happened to those other numbers of B4, 8, 10, and 11? And as we said back in 1912, when Dr. Funk in Poland was naming his vitamins and discovering more and more of these entities, some were actually identified as vitamins in the sequence, but found out later to not really be vitamins, and that's what happened with these big four. Vitamin B4 is adenine, which is synthesized by the human body. Vitamin B8, adenosine monophosphate, is synthesized by the human body as well. B10 was para-aminobenzoic acid, and B11 was steryl heptaglutamic acid, which was one of the 5 folates necessary for humans. So it kind of went back to vitamin B9 or folic acid. So that's what happened to vitamin B4, 8, 10, and 11. Of no great therapeutic interest to us pharmacists, but always good if we're doing trivial pursuit. And I think when most of us pharmacists are thinking vitamin C, we have to think of Linus Pauling, who I have pictured here. He was indeed the guru of vitamin C. Vitamin C comes to us in our normal diet from citrus fruits, tomatoes, potatoes, cabbage, and green peppers. Its deficiency states, no surprise, was scurvy, which was due to those increased requirements or low intake. Became common during long voyages at sea when we had lack of fresh fruits and vegetables, and it was discovered by the sailors that if they ate limes or oranges, that it restored the capillaries to their mouth and kept them from bleeding and gave them the strength that they needed. So we see capillary fragility, especially in the mouth where we have so many of those fine capillaries, as well as loose teeth and hemorrhages. In children, we'll see abnormal bone and tooth development and even swollen joints. Adverse effects of excessive vitamin C, and that's probably what most of the Americans are going to suffer from, is renal calculi, GI irritation, and diarrhea at high doses. We do have a drug interaction, and it's a rather beneficial drug interaction. It increases iron absorption. So I tell all my iron patients to take their iron supplement with some vitamin C or at least a glass of orange juice. Vitamin C is also found to be relatively beneficial in decreasing gout flares. Now, what about the common cold? And that's what Linus Pauling was forever preaching about. Vitamin C supplements really do not reduce the risk of getting the common cold. However, people who take vitamin C supplements regularly will have shorter colds and somewhat milder symptoms when they do get a cold. But using vitamin C supplements after the cold symptoms start really don't appear to be helpful. So vitamin C, in summary, does not reduce the risk of getting a cold. It does not have any benefit if you get a cold and start taking vitamin C, but you'll see less severe symptoms and shorter symptoms if you have your vitamin C on board when you get your cold. Vitamin C is an antioxidant which binds up free radicals, and its adequate intake levels for men aged 19 and older about 90 milligrams per day. Women need about 75, pregnant women around 85, and breastfeeding women about 120 milligrams a day. Smokers, or if you're exposed to secondhand smoke, best to add another 35 milligrams of vitamin C. Well, vitamin A's major source is fish liver oils, and you'll remember your grandparents talking about taking their teaspoonful of cod liver oil, which was real rich in vitamin A and D. And so cod liver oil is rich in vitamin A, as well as egg yolks, green leafy and yellow vegetables like carrots, and toxic doses if polar bear liver is consumed. So that's a good piece of pharmacy trivia as well for you. Eating polar bear liver will cause a hypervitaminosis and probably death. So we're not going to open any polar bear liver franchises at our lunch counters in our pharmacies. The deficiency states are night blindness, early sign of vitamin A deficiency, which can progress to xerophthalmia, which is the dryness and ulceration of the cornea. Your optometrist can pick that right up. And it can progress to blindness. You'll see a decrease in health and the integrity of the skin. Adverse events, well, the skin and mucous membranes will see a drying of the mucous membrane, cheilitis, yellowing of the skin, fatigue, nausea, hair loss, headache, vertigo, blurred vision, birth defects, and loss of muscular coordination and dry, scaly skin. It kind of sounds like Accutane therapy, doesn't it? And as we all know, Accutane is very closely resembling vitamin A therapy. And as we were all told as kids, eat your carrots because there's lots of vitamin A. It'll help improve your vision. Multiple vitamin supplements usually contain about 2,500 to 10,000 international units of vitamin A, often in the form of both retinol and beta-carotene. RDAs for vitamin A are kind of strange. They're given as micrograms of retinol activity, or RAEs, to account for the difference in the bioactivities of retinol and provitamin A carotenoids. So we can see, I have a little chart here, the source, if it's dietary, is 12 micrograms of beta carotene equals 1 microgram of retinol. Dietary 24 micrograms of alpha carotene is equivalent to about 1 microgram of retinol, so it's about half as potent as beta carotene. And supplements that we take, the oral supplements, 2 micrograms of beta carotene is equivalent to 1 microgram of retinol, or a retinol equivalent. So it depends if it's dietary or supplements, and as we can see, the supplements microgram for microgram are more potent than the dietary intake of vitamin A. Vitamin A needs to be avoided in a select group of patients, and that is our smokers. Taking beta-carotene actually seems to increase the risk of lung cancer in people who smoke. Especially those who smoke more than a pack a day are at risk. Even former smokers, or people that are exposed to asbestos, and those that use alcohol more than 1 drink a day in addition to smoking. So beta carotene from the diet doesn't really have an adverse effect on smokers, but the oral supplements do. So do not recommend beta carotene or vitamin A supplements to your smoking population. It greatly increases their risk for lung cancer. Depending on where you live in this country, we can see vitamin D deficiency in as high as half of our female population, simply because here in central Pennsylvania, where I am, depending on the season, you might get a lot of vitamin D being made in your skin when you're cutting the grass, and for 6 months out of the winter, you're not making any vitamin D. The sources for vitamin D: fish liver oils, as we said with vitamin A, egg yolk, fortified milk, and it is also synthesized by our skin when it gets exposed to ultraviolet light. Vitamin D3 comes from animal sources, and vitamin D2, ergocalciferol, comes from plant sources. So vitamin D3, the one that we sell out front, comes from an animal source, that's cholecalciferol, but the vitamin D2, that Drisdol is the brand name, the 50,000 unit vitamin D in the back, is ergocalciferol, which comes from a plant source. The function of vitamin D, it acts as a hormone and plays a role in calcium homeostasis. Deficiency states can be caused by an inadequate intake, a lack of sun or exposure. Even using sunscreens can cause vitamin D deficiency. But as a dermatologist told me once, Pete, I can cure vitamin D deficiency a lot easier than I can cure skin cancer. So please continue to convince your patients to use sunscreens to prevent skin cancer. Also, renal failure, hypoparathyroidism, estrogen, and phenytoin and phenobarb, those can all speed up the metabolism of vitamin D. Fat malabsorption and high alcohol consumption can also decrease our levels of vitamin D. Rickets is the name of the disease state. It is still common in tropical countries, and it's kind of an anomaly when you think about it with all the sun exposure that they have. Low blood calcium and phosphate occur because of vitamin D deficiency, and the lack of vitamin D stimulates the parathyroid hormone to restore calcium levels. And where does the calcium come from but our bones? So we have to make sure we have adequate vitamin D, adequate calcium to keep our bones strong. The dose for vitamin D is recommended between 800 and 2,000 international units per day, and at 2,000 units per day over the counter is the top end that we'll want to recommend as pharmacists without having the blood tests to see if indeed they are deficient. So often our patients will say, can't I just drink milk? Or I drink milk every day. Do I really need a calcium supplement? Do I really need a vitamin D supplement? Well, as we all know, our milk is fortified with vitamin D, and we can recommend up to 2,000 units per day without doing that blood test, that 25-hydroxy vitamin D. When you grab a quart of milk and calculate it out, it takes about 5 quarts of milk a day to get that 2,000 international units, which would be 3,000 calories per day. It also takes about 5 tablets of calcium carbonate with vitamin D 600/400. So you can see that sometimes in our deficient patients, we really need to use a good potent strength of vitamin D like the 2,000 international units over the counter. As far as vitamin D measurement goes, if we take that 25-hydroxy vitamin D and it's less than 12, it's associated with vitamin D deficiency and can lead to rickets in children and osteomalacia in adults. If that level's between 12 and 20, it's considered inadequate and they do need to supplement. Over 20 is going to be adequate, and over 50 is going to be excessive. So approximately 5 to 30 minutes of sun exposure between 10 a.m. and 3 p.m. at least twice a week to the face, arms, legs, or back without using a sunscreen will allow your body to generate enough vitamin D on its own. That being said, we really should protect our bodies from those harmful rays of the sun to decrease skin cancer. Again, easier to treat vitamin D deficiency than it is to treat skin cancer. Vitamin E gets a lot of press. It comes and it goes. It's an antioxidant. It protects the cells from the damage caused by free radicals. Free radicals are produced from the conversion of food to energy. People are also exposed to free radicals just in their environment by breathing cigarette smoke, by air pollution, and ultraviolet light from the sun. There are 8 naturally occurring tocopherols, but the most active one is D-alpha tocopherol. And how I tell my students to remember that is when you tell a patient to buy vitamin E, tell them D-alpha tocopherol, D-A-T, DAT. That's the one you want to recommend. Vitamin oils, wheat germ, leafy green vegetables, and egg yolks, margarine, and legumes are all good sources of vitamin E. Vitamin E is not for everyone, however, and the selenium and vitamin E cancer prevention trial, the SELECT study, was published by the Journal of the American Medical Association, and they showed a link between taking vitamin E over 400 international units per day can cause an increase in prostate cancer in men. The researchers found that the increased risk means that there will be 1 to 2 more prostate cancers per 1,000 patients who took high-dose vitamin E for 1 year. Interestingly enough, the men who received both vitamin E and selenium, there was no increased risk in prostate cancer. So we also want to be careful with vitamin E in our warfarin patients because there is an increased bleeding risk with anticoagulants such as warfarin. Speaking of warfarin, vitamin K, which is the archenemy of warfarin, that's who does battle in our bodies, is warfarin and vitamin K. Vitamin K comes to us both from our natural production in our gut, but also green leafy vegetables, vegetable oils, liver, and synthesis by our own intestinal flora. The function of vitamin K, well, it's essential for the formation of clotting factors 2, 7, 9, 10, and protein C and S. Its deficiency states can be caused by excessive antibiotic use. Newborns and preemies are at an increased risk, and our cystic fibrosis patients, both because they're on antibiotic therapy a lot, as well as that steatorrhea, that diarrhea that has all the fat in it, can also wash out the fat-soluble vitamins like vitamin K. A vitamin K deficiency can cause hemorrhage due to prothrombin deficiency. Our vitamin K stores are small. It being a fat-soluble vitamin, we think it's stored longer. Actually, we only have about a week on board of vitamin K. Kind of an anomaly when you think about it. With our B12 stores, which are on board for 2 years, it being water-soluble, vitamin K being fat-soluble, we only have about a week on hand. Phylloquinone is vitamin K1, and that's found in plants. Vitamin K2 is that major storage form in animals. Many bacteria, like the E. coli we have in our gut, will synthesize vitamin K2 and store it for our use. All of us that have dispensed warfarin since President Eisenhower in 1955 are well aware of the food-drug interactions with warfarin. And warfarin antagonizes the vitamin K in the clotting cascade. So we have to be a little judicious with vitamin K intake. I tell my patients, be consistent. That's the most important thing you can do, is eat consistently. And I've had patients that had way out of whack INRs when they started to lose a lot of weight from just eating all salads, and it really threw their INRs out of whack. So counseling points, if there are very rich vitamin K foods, those that are high in vitamin K, those extreme greens as I call them, kale and spinach, collard greens, Swiss chard, parsley, the real green greens, they should really limit to about 1 serving a day. And those moderately high ones limit to about 3 servings per day of the broccoli, Brussels sprouts, endive, and green lettuce. So just because you're taking warfarin, patients, you still should be eating a good, healthy diet. And make sure it's a good, healthy, consistent diet. We do see a lot of iron deficiency in my practice. Not to the effect that you're going to see it manifested in the fingernails. The spoon nails are soft nails that look scooped out. The depression is usually large enough to hold about a drop of liquid. It's a sign of iron deficiency anemia. Hemochromatosis is excessive iron in the liver, and heart disease and hypothyroidism can all cause iron deficiency. Bone marrow response to iron is limited to about 20 milligrams a day of elemental iron. So no matter how much you take, your bone marrow is only going to be able to latch onto and process about 20 milligrams a day. An increase in hemoglobin level of about 1 gram per deciliter should occur about every 2 to 4 weeks. And it may take about 4 months of iron therapy for those stores to return to normal after we correct that hemoglobin. So we want to avoid sustained release iron for initial therapy. There is just a small spot in the duodenal villi that actually does the absorption of iron. So because of that, we don't want to use sustained release iron because it's going to bypass that hot spot that absorbs the iron out of the gut. I really encourage my physician assistant students to write prescriptions for ferrous sulfate therapy. First of all, I think you get into the head of the patient a little bit better when they get a prescription. They know it's serious that they take this supplement. And secondly, the pharmacist interaction is very valuable with this drug. We really need to get out there and talk to our patients about iron therapy. First of all, which iron? And I tell my students, right, for ferrous sulfate 325, it's the cheapest. We're going to get about a 20% yield on our iron. We get about 12% on ferrous gluconate and about 33% of ferrous fumarate. But when we look at the dollar analysis of it, ferrous sulfate gets you the most bang for the buck. I'll tell them to get a patient on ferrous sulfate 325 milligrams, ideally 3 times a day, but you'll want to start slowly. Start them out on a tablet a day, usually at bedtime on an empty stomach. You will get a much better absorption of the iron if it's on an empty stomach. If you take it an hour or two before a meal, you'll get a better absorption because food can decrease the absorption by about half. Orange juice or vitamin C can double the absorption, so about 200 milligrams is needed to increase about 30 milligrams of elemental iron. So it takes a pretty good dose of vitamin C to do that. If you take it 1 hour before or 3 hours after antacids is good, and if GI upset occurs, which it very well might on iron therapy, tell them to take it with a small snack, some crackers, some orange juice, just avoid milk or tea. And if constipation occurs, we can use a stool softener with Docusate. Brand name would be Colace, but any of the generic stool softeners would be effective. Lots of drug interactions with iron. Extended release or enteric-coated formulations have been found to transport the iron right past that hot spot in the duodenum and proximal jejunum where that absorption occurs. So let's avoid the sustained release products. Vitamin C is added to some products to enhance the iron absorption. We need to avoid fluoroquinolone therapy concurrently with iron, tetracycline therapy concurrently with iron, and digoxin therapy concurrently with iron therapy. The most important interaction with all of this is levothyroxine. Your patients need to avoid their synthroid or levothyroxine dose by 4 hours if they are taking iron therapy. That is critically important. When I'm scanning charts at one of the clinics I work at and I see that the TSH level is 14 or 15 and they're already on levothyroxine 125 mics, first thing I look for, and I always find it, is iron therapy, and make sure you are counseling those patients. Even my wife, who's also a clinical pharmacist, says that she has doctors telling her that they've had patients with virtually negligible thyroid in their system, all because they were taking their thyroid and their iron together. And even some nurses I've talked to told me that they'll see iron and synthroid given at the same med pass at a nursing home. So we really need to get the word out with levothyroxine therapy and iron never to be given concurrently. I'll tell my patients if they're taking iron 3 times a day, they can take their levothyroxine and put it next to their toothbrush and take it at bedtime. Remember to insist on child-resistant packaging if there's any chance that small children may be in the home. Even if grandma's taking her thyroid and she's home by herself most of the time, that easy open vial can be a real problem when the grandkids come to visit, because iron is still the #1 cause of pediatric failures due to toxicity. This next slide shows us the recommended daily allowances for calcium. And you can see once a child reaches the magic age of 4, they should be on about 1,000 milligrams of calcium in their total recommended daily allowance. So they should be drinking their milk, and they should be taking their cheese and their vitamins and eating a healthy diet. Kids in that growing phase do need a good bit of calcium, and you can see that 1,000 milligrams of calcium carries out for that patient the rest of their life. And then the question quickly becomes, well, which calcium should we take? Calcium carbonate comes from oyster shells. Calcium carbonate, the brand name is Ozcal, and there's lots of generics that we all recommend, contains about 40% of calcium, which is about 500 milligrams of calcium per tablet. That needs to be taken with a meal. Optimal absorption occurs in the presence of gastric acid. We need that acid on board to help dissolve the calcium. It can cause constipation, so we want to divide those doses, and you should really never take more than 500 milligrams as a single dose. I always say it's easy to remember that calcium carbonate requires acid for dissolution because it's made from oyster shells. And when you think about it, if just plain water dissolved calcium carbonate, oysters would either be homeless or naked. Calcium citrate, however, does not require acid for dissolution. It contains about 21% calcium by weight. Citracal is its brand name, and it can be taken with or without meals, and it doesn't have that requirement for stomach acid. It's going to be a great choice for your patients who are on proton pump inhibitors or H2 receptor antagonists, and it's going to work best for those patients that are complaining of GI upset when they take their calcium therapy. And we're all aware of the calcium drug interactions with the tetracyclines, and of course fluoroquinolones will see decreased efficacy. Best to avoid calcium and levothyroxine and the bisphosphonates by about 4 hours. Corticosteroids will decrease the absorption of calcium and over time can lead to osteoporosis. And thiazide diuretics increase urinary calcium reabsorption. So thiazides are good guys. They really do help us retain that calcium. Loop diuretics will increase the excretion of calcium, but the thiazide diuretics help us to retain calcium and are actually protective against osteoporosis. I have become very aggressive in vitamin supplementation recommendations over the counter. And the reason I do that is because there is so much bad information out there. How many strip malls do you go by that has a vitamin shop or a natural products shop that they're just wholesale pushing vitamins on everyone? So I've really kind of made it my campaign, especially with my students, to make them aware of the pharmaceutical-induced depletion of vitamin supplements. So I have attached to this lecture as a PDF file some freebies or some shelf talkers for you. And I want you to look down through the list and please steal these. You have my permission to duplicate, photocopy, make your own, cut, copy, paste, do whatever technology you have at your store. I have these little signs hanging around my vitamin section in front of, say, my calcium supplement section. Are you taking proton pump therapy? And then listing some of those. You may not be getting enough calcium, so I recommend calcium citrate. So please feel free to steal any and all of the stuff I've provided for you so you can make all the signs you want to in your pharmacy to promote vitamins, because we pharmacists are the drug experts, and no one is better than for recommending vitamins than your community pharmacist.